Now, coming to the last section, as I just told you that we have briefly covered spina bifida in the last section. But spina bifida is not an isolated disease. It's usually associated with multiple other anomalies of the spine in form of scoliosis, associated hip dysplasias. There may be associated with knee recurvatum, foot deformities in form of calcaneal valgus deformities such as congenital vertical torticollis, congenital vertical talus, and associated with toe abnormalities such as clotos as well. Now, once the patient does comes with spina bifida, we need to rule out whether it's associated with the syndromes or not. For that, we have to quickly scan through the regional systems as well. In this section, we're going through the regional survey of those patients which usually present with congenital anomalies and along with a very rare disease called as sacral agenesis. So, how to go about if a patient has presented with spina bifida or the child is born with spina bifida, then what are the different treatment options available? That is either it's neurosurgical closure that effect possible, or is intrauterine surgery in case of open or fetoscopic surgery. Is it possible if we diagnose that early? Then there will be neural tissue which usually if it is present with dura, then can it be closed or not? Or as it is usually associated with hydrocephalus, sometimes if we cannot do anything about the spina bifida, we do at least ventroperitoneal shear so that the increased amount of CSF can be drained back into the peritoneum from where it can be absorbed. Therefore, the hydrocephalus, which is one of the complications which will further lead to more complications, can be done. Other options include physiotherapy and splinting in case of knee recurvatum if it's not a serious problem, or use of botulinum toxin injections if associated with muscle contractures and severe deformities. Depending upon what is the problem, it could be multiple other problems and we have to deal with them as well. For example, there could be late functional outcome in case of spina bifida that cannot be predicted. Myelomeningocele patients usually never function independently. It is highly unlikely that they're going to carry out activities such as walking and doing their activities of daily living on their own. Usually, there may be decreased development of intellectual skills. As I told you, sometimes the hydrocephalus the pressure is so high that eventually there is always history of delayed milestones, and there may be other problems which may be due to high CSF pressure, which could be causing to decreased intellectual prowess in these patients. There is usually complete paralysis. Even if some muscles do recover, they usually are not good enough so that they can ambulate independently. There may be sometimes, as it is an upper motor neuron region, there may be associated with spastic paralysis. Sometimes to compensate, this would result in some kind of fixed flexion contractures or fixed extension contractures, so that to relieve the child of those contractures, to make the joint more supple, sometimes immobilization and muscle imbalance may be required in form of orthosis or in form of any surgery. So as I just told you, they're usually allergic to latex in form, and for that we can give corticosteroids and antihistaminics. Coming to the regional survey, these patients with spina bifida will have multiple other anomalies. Right from spine, they may be having scoliosis, associated hip dysplasia, knee recurvatum, foot abnormalities in form of calcaneal valgus foot and clotos. So if in case of spine, it's associated usually distal teething of the cord. It's inevitable after repair of the myelomeningocele because usually the posterior lamina are absent, results in pain and neurological dysfunction. Although it's harmless, but it's not actually causing any problem, but this is one of the complications of the surgeries of the spina bifida. This could be associated with kyphosis. Usually, if we see the spinal cord from the sagittal view, there is associated lordosis at cervical, lumbar level, and thoracic level. This is associated with kyphosis. Hyperkyphosis of thoracic usually means there is a crease problem, and this would result in compression of those organs which are present in the chest, for example, lungs and the heart. Therefore, the treatment could be stretching and breakdown, or there could be leading to chronic ulceration as well. And sometimes the kyphosis may be so severe that sometimes a surgery may be required. Then other includes neuromuscular scoliosis. Usually these children present with infantile scoliosis, and it is associated with the left-sided thoracic curve, which has a very high propensity for progression, and sometimes very early surgery may be required. Otherwise, the curve will progress to such extent that it will cause right-sided cardiopulmonary failure, eventually leading to death. It's usually a C-shaped curve. This could be molded seed inserts are a problem because these children cannot sit properly in the chair as well. Sometimes we have to move towards surgery very early in form of anterior and posterior spinal fusion. Other associated problems could be hip dysplasias. Usually, and if you get an X-ray AP view of the hip, this may be associated with malformed hips, or usually the L of the IDM may not be found properly. The treatment for those hip dysplasias include knee, ankle, foot orthosis. Usually is advised. Why? Because this actually helps to support the lower spine over the pelvis. Other options could be, usually we have to start initially with less options which are less surgical. Then could be reciprocating gait orthosis. Then, but if the lesions are above L1, this may result in flaccid splintage of the muscle, paralysis. But if it's below S1, usually hip flexion contracture is associated with it. If it is associated with hip flexion contractures, yes, surgery can be done, but not always surgery has a very good results. Sometimes in between lesions may be associated either spastic paralysis or increased flexion contractures, and depending upon whether it's sometimes they say that below 3 you can go for surgery unless the neurological abnormality. But if it's usually above L3, there is very high likely rate of failure of the surgery. Usually we do not go for surgery in this case. This sometimes, if its hip is unreduced operative because of contractures, they may be associated with hip dislocation, where closed reduction may not be possible, and therefore we have to go for open reduction of this hip in these children. Coming to other, then I told you there's a knee, it's a foot, and there's a claw, toes. There's multiple other abnormalities may be present as well. Knee includes the recurvatum of the knee, that is the hyperextension. Usually the normal range of motion at knee is from -10 degrees till 130 degree, but their knees may be hyperextendable or a high degree of recurvatum. For that, wearing orthosis, usually gait training devices are required. Physiotherapy and serial casting may be initially helpful so that the contractures of the knee can be removed. This may be associated with hamstring lengthening because increased recurvatum would lead to contractures of the quads. This may be so if there is associated with flexion contractures, then there's always a less of a problem, but that also requires sometimes with initially splintage and orthotic devices may be given, then later on surgery may be done as well. Other includes usually they have hyperextension contractures. For that, hamstring lengthening is done. Other options which could be for flexion contractures include PY quadriplasty and hamstring lengthening or relocation. And use of forearm crutches and swing through the gait is sometimes limited. Therefore, treatment options in case of knee include to start with splintage and physiotherapy so that the tissues are stretched actually. Then from physiotherapy and splintage we can move to orthosis. From orthosis, sometimes maybe casting can be done so that with cast gradually deformity can be corrected. But once if the contracture is not corrected, then eventually may have to move for VY quadriplasty of the quads, or hamstring lengthening could also be, depending upon whether it's a recurvatum or it's a flexion contracture. Now coming to foot deformities, as I told you, they may be associated with congenital vertical talus and usually the calcaneal valgus deformities as well. And if it's associated with the congenital vertical talus, sometimes this is a very severe form of CVT, and we may have to initially go for stretching exercises, and then serial casting and via reverse post study can be done as well, or we may have to move for soft tissue procedures very early in these children. As if it is associated with talipes equinovarus, usually they're resistant to treatment, and we have to move towards soft tissue procedures early. Treatment includes appropriate padding, use of orthosis, Ponsati technique for manipulation in case of CTEV, and they may be associated with, if it may require, if it associate equinus may require tendo Achilles lengthening or tenotomy. But if it is associated with CVT, then it will require reverse Ponsati and special shoes called as UCBL orthosis. Then, if in case of advanced stage disease, there may be associated with tendon transpose as well. Tibialis, anterior tibialis tendon may be had to transfer to the talar neck. Lastly, we are coming to another rare disease called as sacral agenesis. It's a rare congenital disorder in which there is abnormal development of lower spine and other organ systems in the lower half of the urogenital and GI systems. Usually severity varies. Patients behave like a low-level spina bifida. Actually, it's absence of sacrum. There's absent sacrum and lower lumbar spine as a whole. Usually, the legs are seen in a Buddha position. After the Buddha used to sit in for meditation. Classically, they're abducted and flexed at a certain angle, along with the forward flexion of the spine. In this section, we have briefly gone through the complication may be associated with spina bifida. Remember, spina bifida is not a natural disease. It presents with kyphosis, scoliosis, and we may have to deal with these complications as well. Kyphosis can be dealt with anterior posterior fusion, or sometimes we may have to go for early surgery in case of scoliosis as well. And if there may be associated hip abnormalities, which can be corrected usually with physiotherapy and knee, ankle, foot orthosis, but sometimes if it is associated with dislocation, surgery may also even be required. In these patients, not only have problems with the hip and at the spine, but also at the knee and the foot as well. In knee, they usually recurvatum and hyperextension contractures, which may be corrected eventually with V by quadriplasty or hamstring lengthening. And in case of foot, these patients usually present with congenital vertical talus, in which the talus is usually quite vertical and may be corrected initially by stretching exercises. Then later on, reverse Ponsati can be done for them. And if we have to move towards early soft tissue procedures in case of these patients. That's all from this section. Keep watching sqadia.com. Thank you very much.